Let's talk about acute upper GI bleeding. It's actually one of the most common reasons people end up in the emergency room. But what's really going on inside the body? And how do doctors take what looks like a totally chaotic situation and turn it into a clear, controlled plan? Well, today, we're going to demystify this whole process. We'll follow the patient's journey from the very first sign of trouble all the way to recovery.
You know, this kind of thing often hits completely out of the blue. One minute you're fine, and the next there are some pretty alarming signs that something is seriously wrong. And that's exactly where our journey begins, right at the sudden start of this medical event.
So the most common way this whole thing kicks off is with a symptom called hematemesis. It's just the medical term for vomiting blood. But here's what's really interesting, and you can see it on the slide. The blood can look two very different ways. If it's bright red, that tells the doctor the bleed is probably fresh. It's happening right now. But if it looks like coffee grounds, that's a huge clue that the blood has been sitting in the stomach for a bit, mixing with stomach acid. Either way, it's a major red flag.
Okay, so besides hematemesis, doctors are on the lookout for a second key sign called melena. This is what happens when blood passes all the way through your digestive system. It gets altered along the way and results in this black, tarry stool. It's that same reaction with digestive juices that gives you the coffee ground look. A patient might have one of these signs, or they might have both. But for a doctor, either one immediately points to an upper GI bleed.
Now, beyond what you can see, there are hidden clues in a patient's blood work. In this quote, this illustrates one of the coolest ones. See, when you bleed into your gut, your body actually starts to digest that blood. And since blood is packed with protein, your body treats it like you just ate a massive steak, a protein meal. That whole process releases a substance called urea into your bloodstream, which pops right up on a blood test. It's a really subtle but powerful piece of evidence.
All right, so the team has identified a bleed. The alarm has been sounded. Now the next phase begins. This is where the real medical detective work starts, where they have to figure out exactly where the bleed is coming from and what's causing it.
The term upper GI isn't just a vague area. It refers to these three specific spots: the esophagus, the stomach, and the duodenum. That's the very first part of your small intestine. The problem is lurking in one of these three places. So let's look at the main suspects, starting from the top and working our way down.
So starting in the esophagus, you've got two common culprits with totally different backstories. On one hand, you have esophageal varices. These are basically swollen veins, and they're often a side effect of chronic liver disease. When these go, they can cause a massive, scary bleed. On the other hand, you have a Mallory-Weiss tear. This is a rip in the esophagus lining that's usually caused by a really bad bout of vomiting. The patient's recent history is absolutely crucial for telling these two apart.
Now we move down into the stomach. Gastric ulcers are a classic cause, right? They can just slowly eat away at the stomach lining until pop, they hit a blood vessel. Then you've got gastritis, which is just inflammation of that lining, often tied to taking NSAID painkillers like ibuprofen. And then you have the Dilafoy lesion. This one's rare, but it is so dangerous. It's an abnormal artery that's way too close to the surface, and it can just rupture without any warning, causing a massive bleed. And finally, we get to the duodenum. Ulcers are a big problem here too, but with these, it's all about location, location, location. An ulcer on the back wall, the posterior side, is especially dangerous. Why? Because it can literally erode right into the gastroduodenal artery, a major blood vessel, and that can lead to a catastrophic hemorrhage.
Okay, so we've got our list of suspects. But before the team can jump in and treat the bleed, they have to answer another critical question. Just how bad is this? Figuring out the severity of the bleed is absolutely key to deciding what to do next.
To get a handle on the risk, they use a tool called the Glasgow-Blatchford score. Now, this isn't for figuring out the cause of the bleed. Its whole job is to assess the risk right there at the start. It helps doctors make a really practical decision. Does this patient need to be admitted to the hospital right now for urgent care? Or is the bleed low risk enough that they could potentially be managed as an outpatient?
The score itself is pretty straightforward. It's a point system based on the clinical markers you see here. The doctor will look at the patient's blood test results, like their urea and hemoglobin levels, and check their blood pressure. The more out of whack these numbers are, say a really high urea or a really low hemoglobin and blood pressure, the more points get added to the score. More points means higher risk.
And here is the magic number, 0. If a patient's total score adds up to 0, it means all their vital signs and blood work are in a good range. This is a fantastic sign. It flags them as very low risk, and often they can be considered for early discharge, avoiding a hospital stay they don't actually need.
All right, so the patient's in the hospital. Their risk level is known. Now it's time to actually fix the problem. And this isn't just guesswork. There's a very clear, well-established plan, a management pathway designed to get the patient stable and stop the bleeding for good.
This whole pathway really boils down to 3 core steps, and they happen in a very logical order. First, you resuscitate. Second, you investigate with an endoscopy. And third, you deliver a specific, targeted treatment based on exactly what you find.
Step 1 is all about stabilization. First things first, before you can even think about hunting for the source of the bleed, you have to manage the immediate emergency. That means the ABCs: airway, breathing, and circulation. Doctors will get big IV lines in, pump in fluids, and if there's been a lot of blood loss, they'll give blood transfusions to replace what's been lost. Once the patient is stable, it's time for the endoscopy. This is where they send a thin, flexible tube with a tiny camera on the end down into the esophagus, stomach, and duodenum. It lets the doctor see exactly what's going on and pinpoint the source of the bleeding. And the guidelines on this are crystal clear. Every patient needs to have this done within 24 hours of showing up.
And this brings us to step 3, which is where the path splits depending on what that camera found. If it's variceal bleeding, they give a specific drug before the scope even happens to lower the pressure in those veins. Then, during the endoscopy, they treat them with tiny elastic bands. But for non-variceal bleeding, like an ulcer, the treatment is different. They'll often clip the bleeding vessels shut right then and there. Afterwards, patients get powerful acid-suppressing drugs called PPIs to help everything heal. And of course, in the most severe cases, surgery might still be needed.
So there you have it. From that first scary symptom to a highly specific treatment, managing an upper GI bleed is a fantastic example of a clear medical process in action. It is a serious emergency, there's no doubt about it, but having a fast, structured approach makes all the difference. And it kind of makes you wonder, right? What other really complex medical emergencies start to make a lot more sense once you understand the step-by-step process for tackling them?